Very good evening to all my dear MOS members and the ophthalmic fraternity who have joined today. A very interesting webinar has come up. This time is on Epiphora. We had taken the subject as preferred practice guidelines. Dr. Honavar, our speaker, has fallen ill and has running temperature. So Dr. Ruchi Goyal ma'am and Dr. Savri Desai, on the last moment, she has taken up the topics. So it will be nevertheless very interesting for you people. It will be definitely going to help each one of you in your private practice. So we have the Dr. Ruchi Goyal ma'am. She is a professor. I know her. She is quite humble, but very well read, very good accommodation. And Dr. Savri Desai also, a good friend of mine. She is a pass out from KEM Pune and doing pure oculoplasty work. I now we welcome Dr. Rajesh Joshi also, our honorary secretary, and Dr. Neha Srirao. She is our moderator and she is going to run the whole session, moderate the whole session first, introduce Dr. Ruchi Goyal. So over to you, Dr. Neha.
Hello.
Yeah.
Yes. So, welcome everybody. I would like to give a short introduction to our speakers. Just a minute. Today we have with us Dr. Ruchi Goyal, who will be speaking on Epiphora. Dr. Ruchi Goyal is currently affiliated with Maulana Azad Medical College, Guru Nanak Eye Care Center. She is the examiner for FRC Ophthal London and the reviewer of OPRS, Orbit, Cornea, and multiple other journals. She has many publications in peer-reviewed journals, more than around 100 articles and 33 book chapters. She is also a part of 3 CME series of AIOS. She's been bestowed with various academic awards like VP Chadda Memorial University, Gold Medal Award from the Delhi University, Mrs. Rukmani Gopal Krishnan Memorial Gold Medal Award, AIOS APO Honavar Award for the Best Paper in Lacrimal Session, AIS IGO Silver and Outstanding Paper by International College of Surgeons. So, with this great this behind her, she will be enlightening us on a few scenarios with patients of Epiphora. So over to you, Ruchi Goyal ma'am.
Warm welcome, ma'am. Professor Ruchi Goyal ma'am and Savri Desai, both of you. Yeah, over to you, ma'am.
Okay, thank you so much. I'll share my screen. So my screen is visible now?
Yes.
Okay.
Yeah, ma'am.
So I will be speaking, Epiphora is one of the commonest complaints with which the patients present to our OPDs. And though it looks so trivial, it is so troublesome to the patient that the patients keep on flocking to the OPDs, and multiple times the diagnosis is incorrect. So just to cover the reasons why we make a mistake and some of the challenging situations which we encounter in the management. So what are the causes of epiphora? Most of them would be, of course, the obstructive epiphora, and many times there would be some reflex causes. And whenever we have a patient of epiphora, we must examine the patient properly, because there may be some ocular surface issue which may be leading to watering. At times there would be some foreign body lodged somewhere in the fornices, and they may be the cause of epiphora. So a thorough ocular surface examination is a must before we embark on any kind of intervention. Now, obstructive epiphora could be right from the excretory system of the tears. It's going to start from the punctum, and so if you look here, so the obstruction can be at any level. Most of us are very comfortable managing obstructions happening somewhere in NLDO region. But any obstruction which is happening in the proximal area, may it be punctum and the the individual canaliculi and the anterior proximal portion of the common canaliculus, these have very poor reproducibility. And we try to just keep reassuring the patient. And nowadays a lot of people have started giving Botox in the lacrimal gland for these kind of epiphora. So just to go run through the different scenarios, a very common again scenario would be something called an involutional ectropion of the lower lid or entropion of the lower lid. That causes epiphora, and it always affects the lower lid, and that happens because of the weakening or the dehiscence of the capsulopalpebral fascia. And there is overriding of the preseptal and the pretarsal fibers, which there is following which there is a lamellar dissociation. And the patient may have a horizontal lid laxity, or there may be a medial canthal laxity, or there may be a vertical dissociation. That means the inferior lid retractors may have got dissociated from the inferior tarsal border. So one must first ascertain as to what is the cause of epiphora, and the commonly performed tests are of course the pinch test, and to see the medial and lateral canthal laxity, we just pull up the lateral canthus a little laterally, and you see how much movement of the punctum is there. If it is more than 2 millimeter, it indicates again a medial canthal laxity. Why is it important is that if you try and treat the lower lid laxity with the traditional method, the commonest nowadays being the lateral tarsal strip procedure, and you have a medial canthal laxity, what happens is once you pull up the lateral canthus, the punctum tends to get dissociated and it moves laterally from its normal position. So one has to be careful as to which procedure one chooses to treat these patients, and accordingly plan. Now this is one of innovation. This is the subdijang suture, which was initially described by us for Centurion Syndrome. And Centurion Syndrome, again, these are young males who present with epiphora, and that happens due to the anterior insertion of the medial canthal ligament. So what is done is that tightening of the lower lid is done using a fibroproline suture, which is passed from the medial canthal tendon to the lateral canthal tendon with a bite of periosteum. And this is how you do it. This is you make very two small incisions, about 2 millimeter at the medial canthal area and the lateral canthal area, and a proline suture is then passed. And this is how, after tightening, I always bury the proline suture. This is a patient of Centurion Syndrome. Similar thing can be done for patients with senile ectropion or senile entropion also. And again, the procedure is same. Only thing is here, because of the laxity of the lower lid, sometimes you have to pass the proline suture on a straight needle in 2 bites. So the video will just show you how to do it. So this is the straight needle on the proline, fibroproline, and the plane which is being followed is just pretarsal plane below the orbicularis, closely hugging the lid margin. And you take it out on the opposite side, and then you tighten it and you tie it to the canthal ligament as well as a bite on the periosteum. Otherwise, it tends to pull away. And we published this study and we compared this with the lateral tarsal strip procedure, which is the traditional procedure which we all are practicing for both entropion and ectropion, and we found comparable results in patients with mild to moderate ectropion. Now, this is again a very common procedure. This is the medial conjunctivoplasty, which is being done for medial ectropion, again a cause of epiphora, very commonly encountered. So you do a diamond-shaped tarsoconjunctival resection, and this edge of the diamond has to be about 4 millimeter below the punctum so that it does not injure the punctum. And then you take the bite so that you cause a shortening of the inner lamella, and then you bring out the sutures and you tie it on the skin side. So again, a very effective procedure. I have not gone into, there are multiple procedures that can be done. I've just touched upon the simplest and the easiest ones. And of course, lateral tarsal strip, we all practice for the ectopins. Now, going to the anatomical blocks, as I said, if you start from here, when we talk of the proximal blocks, uh, different classifications are again available. So Dr. Mohammed Javed Ali, or somebody who's really an authority on lacrimal, he had published an article where he divided the canaliculus into proximal would be about up to 3 millimeter from the punctum, mid-level is 4 to 6 millimeter from the punctum, and distal is more than 6 millimeter from the punctum. So anything which is happening over here, we call as proximal. Beyond this would be mid-level, and after that would be distal. Now, as we go, the two canaliculus, they join and form a common canaliculus, and obstructions which are somewhere beyond 8 millimeter, they are not very difficult to handle. And we have published this again study we did that anything beyond 8 millimeter, you can use a sizzler strifine, and you can remove the block and cannulate it with a bicanalicular silicone stent, obtaining very good results. Before you start onto any of these management protocols, one must differentiate, a stenosis from an obstruction. So stenosis would easily open up with, passing a probe and then passing passing a stent. And nowadays, mini Monoca stents have really become popular. And only thing is that the cost factor still bothers all of us because they are a little expensive. But otherwise, mini Monoca stents, they really do well with any kind of canalicular obstructions, may it be at the level of the proximal canaliculus, or the obstruction may be at the level of puncta, where classically we used to do 2-snip, 3-step procedures, and now we have all kind of shifted to creating an opening and then passing a stent and leaving it there for about 4 to 6 weeks. So that really works in our hands, and it's very easy to insert and take it out after 4 to 6 weeks. So now I'll just go through some interesting videos. Now this is I think post-traumatic proximal blocks are very common. So this is a patient with long-standing granuloma formation and telecanthus post-traumatic. So what is the first thing is that you should ascertain as to how much canaliculus is still available to us. So you just pass a probe, and keeping these probes in situ while you're operating is important so that you don't accidentally injure the canaliculus. And after that, you can operate, do an external DCR as you regularly do. Only difference would be your landmarks would be lost, the medial canthal ligament may be lost, so you have to use a anterior lacrimal crest as a landmark to sometimes locate your sac, and it may be displaced. So these are a little different steps that one has to follow. And after that, once the cannulation is done, you can use, this is a Prolene suture to repair the telecanthus. You take a bite from the inner canthus and you tie it to the periosteum. So this is just to show how to retain whatever canaliculus is left with you. So this is another video where this patient had already had a primary suturing done outside somewhere, and the canaliculus was injured. So we tried to locate the cut ends, and this is how you pass the probe and try and locate the cut ends. All these procedures need to be done under high magnification, otherwise it is difficult to look for the canaliculus. And this is a betadine wash being given, and in fact a swab has been kept at the medial canthus to prevent the betadine from going into the NLD, because the upper canaliculus was patent. So you can see the other cut end of the canaliculus could be identified by simply injecting betadine. So it flushed the debris out of it, and also helped us in identifying the cut end. So this is the mini Monoca, which has been shaped in a form of a bevel now, and you just pass it from the punctum. Mind you, you need not enlarge the punctum, because the knuckle tends to get displaced. So you don't need to enlarge it too much. No need to dilate the punctum too much. then you're placing a mini Munoka. It's a very beautiful device. It just goes and sits in there snugly once you put it in. And the only thing is you need to trim it according to the length you need. So most of the time this length is pretty long, so you need to trim it. And after you place the stent into the canaliculus, so it's important that the cut ends of the canaliculus are brought back into position, and you can use a vicryl suture. You can use this is a 6-0 vicryl to bring the tissues together, and then the canalicular edges, they are sutured with a 8-0 vicryl, so that you don't injure the canalicular wall. So now going to blocks which are a little more proximal. So as I said, canalicular trephination and intubation is of course the primary procedure, the most non-invasive. And the intubation, if the sac is intact and you feel only if the obstruction is at the level of the canaliculus, you simply have to use a Sizzler's trephine, and you can put a mini Munoka stent there and leave it. If this doesn't work out, then of course there are different surgeries which are described, balloon canaliculoplasty and a lot of other surgeries. But the commonly practiced, of course, are the CDCR, that is the conjunctival DCR. And this is another technique called retrograde intubation DCR. So this was described way back by these authors, and we try to study this. This is a Bowman's probe. You bend it at 80 degree, and I'll just show you a video how you can go about doing it. So this is the usual incision, and then what is important here is that when you open up the sac, you have to open it up carefully so that you don't injure the common canaliculus. So this is the common canaliculus, which is very beautifully visible. And you must cut the medial canthal ligament when you are doing this surgery, because it doesn't you don't get a very good exposure if the medial canthus ligament is intact. So after that, this probe is passed in a retrograde fashion, and it exits just beyond the obstruction. So you see, it traverses the canaliculus, and it opens, it comes out in an area which is intact, and then again you bring it back to the other canaliculus and take it out. So you now have a new punctum, and we call it as a pseudopunctum. So this is the pseudopunctum which is created, and what we did was that we sutured the opening of the mucosa of this new pseudopunctum. This is how you do the intubation, and I'll just show you the OCT pictures which we got post-op. Rest of the procedure is the way you do it. Any DCR is done. So this is how you suture all around the new pseudopunctum. And these are the post-op 12th month images. And if you see here, this is the actual opening of the punctums, and this is the new punctum which was created. And these are the anterior segment OCT images with the punctum, the new pseudopunctum, which is there visible here in this picture. So we compared this with the external conjunctival DCR, and this is how I do a external conjunctival DCR. I use a straight glass tube and with a cuff, and this is of course the usual way of opening the sac, and this is the partial excision of the caruncle. And then nowadays bone graphy knives are not available, so I used an MVR to create a track. And after creating a track, you measure the length of the tube which is required, and about 2 millimeter less than the distance from the caruncle to the septum. So that is the tube, and this is, see how I suture the bypass tube. This is a mirror tuck technique which is already published in IGO. And this is the first, you take a bite with a 6-0 proline at the base of the tube, the cuff, and after you have taken it all around, you create a mesh on top of the tube like a mirror. This is the cross mesh which is being created. It's a little, you have to do it with patience, because these bites have to be taken carefully, otherwise they tend to slip. And once the cross mesh is created, you take the bites outwards and again bring it out and suture it to the adjacent conjunctiva. So it creates a kind of a net all around the tube, and this keeps the tube in place very comfortably. So nowadays I have given up all other procedures. I always use this procedure, and after that you can just suture check the position of the tube and suture the conjunctival flaps as in any DCR. At the end of the surgery, you must put in fluid and check on the table. See if your tube has been placed properly on table itself, your drainage will occur. Post-operatively, of course, you have to tell the patient to keep on doing deep inspirations every day now and then to keep the patency of the tube so that it doesn't get blocked with the secretions. And you don't have to remove these sutures. And these are some of the pictures of these patients. This is 1 year post-operative. And most of the time this the suture, either if I don't know what happened to the suture, but many patients either the suture was buried inside. Only a couple of patients I needed to remove the sutures, and the track was after some time it got lined with the mucosa. So this is one innovation. And we compared these two procedures in patients with proximal blocks, and what we found was that the retrograde intubation would work mostly in patients post-infections, and where the blocks were somewhere close to about, let's say, less than 7 millimeter from the puncta. Any block which was beyond 7 millimeter, and also if there was post trauma, there would be multiple injuries, and the remaining canaliculus would also be damaged. Their retrograde intubation would not work, and conjunctival DCR had to be done. But of course, as far as complications and ease to the patient was concerned, retrograde intubation was much more comfortable procedure than the conjunctival DCR. So this is another study we did. We did a conjunctival DCR with the diode laser, and we did it with the external route, and we found comparable results. So it can be done with either of the methods. Now, another situation, that is acute dacrocystitis. Again, the classical teaching is that just wait, keep on giving penicillin group of antibiotics, then you go for an external DCR. I think all our undergraduate books we have been taught not to operate an acute dacrocystitis, because there may be chance of fistula formation, and there may be chances of preseptal cellulitis, orbital cellulitis. So most of these patients would have had multiple courses of penicillins before they end up in your clinic, and still the patients may have a lot of fistulas despite the fact that they had been treated with antibiotics. So I decided that why not go ahead and operate these patients, and let us see what happens. So nowadays a lot of people have started advocating that endoscopic DCR should be done in acute dacrocystitis as a primary procedure. And in fact, I was doing a lot of laser DCR at that time. Now I have shifted to surgical endoscopic DCR. So what I thought was that if I use a laser DCR and create a small opening with the laser DCR, with the laser diode laser, it will act as an IND for these patients. And because all the problems of infection are occurring because of the stagnation of the pus inside the lacrimal sac. So we did this procedure, and just see this is the sac. So first, just to identify where the punctum is, instead of giving a cut, we simply aspirated this abscess. So we send this for culture and sensitivity also, instead of just blindly giving augmentin to all our patients. So after that, this is the punctum which was dilated, and the laser probe was passed after dilating the punctum. So instead of doing an IND, now I have created an opening in the nasal cavity. So there is no question of any fistula formation over here. And I divided these patients into 3 groups. In one group only laser opening, followed by, this is the surgical enlargement of this opening. Initially 4 by 4 millimeter was enlarged to 8 by 8 with the Blakesley's forceps. So in one group I did it with the laser in one stage. In the other group, I first created a 4 millimeter opening and enlarged it with the Blakesley's forceps after in the second sitting. In the third group, I did a external DCR in the third sitting. And what I found was that all our patients, after creating the small opening, they were so comfortable by second post-op day that it was really amazing. So that was one thing was very clear, that this procedure was working very well in acute DCR. Now the question is whether to enlarge in one sitting or two sittings. So patients whom we had enlarged in the same sitting, we had to intervene again and enlarge at a later stage also, because they had more inflammation, vis-a-vis those where the enlargement was done in the second sitting. So, but what we realized was that all these patients should not be just, given antibiotics again and again and IND done to cause scarring and all that. The best is either you do an endoscopic DCR directly, or you can go for this procedure. And we have published our results recently, and they were very encouraging. And now I don't keep, and the other important thing I realized was that all these patients most of these had a resistance to penicillin group of drugs. So what happens is that because of 70% resistance to penicillin, these patients would have recurring attacks. So another take-home message is that all acute dacryocystitis patient, one must send the sample for culture and sensitivity and not give antibiotics as a blanket treatment, the penicillin or augmentin. So this is what we concluded from this study. So I think it's almost half an hour. I'll just conclude and we can take up discussion later. So whenever you have a patient of Epiphora, one must ascertain the cause of Epiphora and then decide what treatment has to be given. Patients with, sometimes dry eye and, as I said, foreign bodies, some trichiasis, all these things have to be kept in mind, and a good examination on slit lamp should be done. Even in patients who apparently appear that they have ectropion and that is causing the Epiphora, you must go and perform syringing, because most of the times what happens is the patient may be having a prolonged eversion of the punctum, and that may cause secondary obstruction. So you must go and perform a syringing before you go in for any ectropion surgery. Now, if you have punctal blocks, you can go in for snip procedures, or you can go in for mini Monoka stents. If you have proximal blocks, then initial intervention would be refination with intubation. If it doesn't work and it keeps on recurring, then depending on where exactly the block is, let us take it arbitrarily. If it is less than 6 millimeter from the punctum and there is not extensive scarring of the remaining canaliculus, you can go in for retrograde intubation. However, if there is extensive damage and it is, quite close to the common canaliculus, or let's say somewhere around 7-8 millimeter, then it is better to go directly for conjunctival DCR, because retrograde intubation would not work. If it is somewhere 8 millimeter and beyond, again, you can go for scissors refination and you can go for intubation. And canalicular DCRs also, they do have very good results. So in a nutshell, I think this is all I would like to speak, and I would be definitely happy to take any questions.
Very nicely covered, ma'am. In such a short notice, beautiful presentation. So many discussing about Epiphora you have covered and the procedures. So nice of you. Over to you, Neha. Is she there?
I think her net is internet. Yeah, now she's moving.
Thank you very much, Dr. Ruchi. That was quite an informative talk. We will be taking some questions in the end. I would now like to invite.
Yeah, we can discuss, break the questions for this right now in case.
You want to take the question?
Because it was such an interesting talk. We can take the question. That's okay, Dr. Jignesh, or you want it later?
Yeah, it's okay. It's okay.
Okay, so any of I would like to actually ask quite a few questions to Dr. Ruchi. What has been your experience specifically with proximal blocks? What kind of I mean, especially those kind of blocks which are post trauma and the canaliculus has not been repaired at primary repair.
See, no, again, thank God that we have two canaliculi. So let's see, although classically both of them should be functional because the patient may have another injury later on, and you may end up. Uh, is there a lag? My net is quite good. I think Neha
No,
is.
it's okay, ma'am.
Yeah,
We can
yeah.
hear you very clearly.
Yeah,
Yeah.
yours is fine, Dr. Ruchi.
So if you have one canaliculus
Actually,
intact, I would not go for a conjunctivitis here. No, I would not do it. Even if it is the lower canaliculus which is damaged, I would just try and first do a trephination. Definitely, I'll try to refine and intubate. But definitive procedures like conjunctivitis, that is usually my last resort. Nowadays, patients who would we as being a government setup, we do have Botox, which is free of charge, which we have it actually for other purposes. But yes, again, this is a therapeutic reason, so we do inject. And about zero point 0.2 ml, 2 units we are injecting in the lacrimal gland, and after 2-3 injections, these patients, they tend to have decrease in epiphora. So that is another modality which can be thought of a little less invasive. And I think a lot of people, Sabri, would agree, have shifted towards Botox injections. But then, not everyone would be able to do that. So yes, as I've already told you, where at what millimeter, what intervention to be done. I practice it that way. But if there is an extensive damage, we have had, patients where there was a road traffic accident, and when we opened up, we found not only the canaliculus damage, because once you're doing a probing, you can just see the one part of the canaliculus. You cannot see how lengthy that obstruction is. So when we opened it up, we found that actually the remaining canaliculus was also damaged, and there were glass pieces sticking everywhere. So these things you cannot define just by probing. Only when you sit on the table, you get to know. So, yeah.
Yes, Neha.
Also, ma'am, as you said, a lot of us have moved to just dilatation of the punctum with intubation rather than actually doing a 3-snip punctoplasty. But how long do you suggest keeping the stent intact? Because there are still a lot of centers who are keeping the stent intact for almost 6 months when the intervention is done from the point of view of canalicular stenosis or punctal stenosis. So what has been your experience when we shifted from 6 months? Earlier we would all keep it for 6 months, and recently we have started reducing the time. So what has been your experience in that perspective?
So Neha, silicone, basically it is a material which has a tendency to collect the biofilm over top of it. So, silicone is a double-edged sword. On one end, it is helping us to keep the canaliculus patent. On the other end, if you have a lot of secretions which are collected in the, along the tube, they itself are a source of subsequent obstruction. So Dr. Javed Ali again has, I think, published a lot of papers, and according to him, like, I started following this protocol and it did work. 4 weeks is actually sufficient for the tube to be in situ. So I usually now like to remove my tube after 4 weeks, and even if my tube is in place, my protocol is that I keep telling my residents to do syringing by the side of the tube. So what happens is whatever collection is happening along the tube, it tends to get flushed. So let's say about initially every week, and then after that, once in fortnight, and after that maybe once a month. So you can just shift on. Since we remove it by 6 weeks, we don't need to follow that longer regimen any longer. Yeah. So again, I would suggest that one should not retain these beyond 6 weeks should be the last when they should be removed.
Yeah, I just wanted to add a point. I totally agree. So regarding the lacrimal gland Botox, I just wanted to add that we do often have patients who come saying that they have a significant amount of watering, and that could not necessarily be obstructive but functional epiphora. So I found that two very simple things in the OPD work. One is when they walk in and they're talking to do a simple Monk score for all general ophthalmologists, which is the number of times they wipe their tears. So there's a simple grading of 0 to 5, which is less than 2 times, 2 times, more than 2 times in a span of like a minute. They've wiped it many times. So often they're saying they have watering, but they don't have, and there's a lot of literature to support it. And Schirmer's is also another thing which we do as baseline before we do consider even giving lacrimal gland, because some of them perceive watering as, oh, certain hours of the day, but it's not continuous. So these are 2 points. I think the dosage is what Dr. Ruchi says, very similar, 2 to 2.5 units. And we have seen a very similar trend with the thing that if you're giving lacrimal gland Botox in the palpebral lobes, of course, technique is important to prevent ptosis. But after 3 injections, it seems to be like this cutoff, which causes some amount of lacrimal gland scarring, because of which the patient doesn't end up coming back to you. Maximum I've given 4. I don't think even Dr. Ruchi must have given more than that. They somehow this decrease and it's beneficial. And coming to the second point about lacrimal intubation, I would probably agree with her that I would initially be very enthusiastic in my early years of practice of keeping it 6 weeks, 8 weeks. But as the years have gone by, I've reduced it from 6 to 4, often even removing it 3 weeks. Because I've had actually patients coming in and saying that they weren't having watering, and now they're finding that there's a little bit of, like she said, the biofilm, that there's some amount of, like just frothy discharge and this. So I think that I completely agree with that. And like she said, Javed has published that and probably is right. I had a question for Dr. Ruchi. A lot of the things she said, especially one of the tightening of the medial canthal tendon, that was something I remember she had published and presented in one of the oculoplasty meetings. And we had like said, oh, okay, there's something else we can do which is not, actually like a medial canthoplasty, which is sometimes like lateral tarsal strip, a surgery to go to, but you don't want to do it because eventually somehow lateral tarsal strips, they are easy surgeries, but they don't always last. So that was one of the things that really worked. But I just wanted to ask regarding the CDCR, what kind of age groups would you early, or would, like you said, you don't do it very often, would you still try and convince the patient to try something else, Retrograde, lacrimal gland, Botox? Because I tried learning it, and then I've just it doesn't work in my hand. So, I mean, I actually just end up referring if the patient wants a second opinion. So what is the criteria you choose?
Okay. One thing is that I have not given Botox to children. So I don't give it in children. So in children, we have no option. So we have to go in for any surgical procedure. The other thing is I just weigh whether that, the child is going to follow the instructions or not. And I have seen patients as young as 6 years who would follow instructions very meticulously. So, you have to actually judge as to how, they would not, some of them would just pull the tube out. So you have to judge whether they are following your instructions. In the OPD, you can choose your patients. So I can't really say that a cutoff can be made as such as age is concerned. Of course, nothing below 5 or 6 years. No, never. So I guess the youngest I would have done would be somewhere or 6 years or 7 years. I'm not too sure exact age. I'm not too sure. But yes, it did work well. And sometimes, of course, you do have to, the track is made, and over the time, because most of these patients would have some kind of a trauma, there would be a lot of inflammation and edema. So the tube tends to get a little displaced. So I have had issues where I had to go back and open up and replace my tube. And in children, because you have to give GA for everything, so it becomes an issue again. So in adults, it is easy. If you have to do any intervention with the tube tilting or something, the sutures, sometimes, there may be granuloma formation on top of the tube. So these things, they can be easily handled in adults. So let us say that my opening statement to the patient is that there is only 50% chance that it may work. I start with that, so their expectations are not sky high, and you have to work equally to keep the tube in place and maintain the patency. So once they agree to all these things, then only I kind of suggest this procedure. Otherwise, I tell them that it is better to live with the Epiphora rather than because it will not work if the patient does not cooperate with you.
Madam, one question from me, like a common ophthalmologist, congenital dacrocystitis, some pearls of wisdom for a proper treatment. People follow different regimens in this. So just give the tips to the common ophthalmologist.
Okay,
how to go about it.
Okay, so most of them say, let's say 90% would resolve if you follow the massage properly. So the mother has to be instructed to give a Krigler's massage, and they don't have to keep on doing every now and then. Because it is what is important is that the sac should be full, and then you press. Then that only would exert pressure enough to open up the blockage. The other thing is that the mother has to be instructed to maintain adequate pressure when she's giving the massage, and the hygiene that has to be maintained by the mother. Otherwise, what happens is they do it with dirty hands, and they end up with a lot of infection. As far as antibiotic is concerned, actually antibiotics, another malpractice is the patients would continue to be on tobramycin for months and months together, which is not required. So if you wash your hands properly and do a good massage, most of these patients would do well, and by usually 6 months, 7 months, 8 months, they do open up. And if they do not open up by that time, then earliest I would like to intervene by, let's say, 9 months, and I would go and do a probing from the upper canaliculus. And again, if again it goes back, then I would go for a repeat probing. And I usually would not intervene before 6 weeks. No, I would not. I would even wait for a longer time. And beyond 3 years, if the patients, they present late, something like again 1.5 2 years, I would again give a trial of probing first. But whenever they are close to 3 years and they present to you late, usually probing, the success rate would come down. And I would like to do probing endoscopic guided, not a blind probing. That is another thing that really helps. You can actually identify and your direction, your placement correctly. And beyond 3 years, I would go for a DCR. I would like to, if it is an infected, biocele kind of a thing, or then I would go for an earlier surgical procedure.
Right, ma'am. Yeah. Neha?
I think our internet is a problem.
Yeah, internet is, I think, having a problem. Savri, you can take over your topic in the meantime. Neha, can you hear us?
Yes, sir. Yes, sir.
Yeah. We're waiting for your questions now as a moderator.
So, I would like to invite Dr. Savri, who is with works with PD Hinduja Hospital in Mumbai. She exclusively practices ocular oncology, orbit, and oculoplastic surgery. She has been she has a special interest in taking surgical videos, because of which she has won multiple awards, especially the Best of Show Video Award at 2006 American Academy of Ophthalmology, Best Video APAO 2009, and Best Runner-Up Special Interest Video in ASCRS 2010. She has also been a recipient of multiple awards regarding paper presentation. The best paper in orbit and oculoplasty at APAOAI was 2013. Gangadhar Sundar Medal for a young oculoplastic surgeon at APO 2013, and a lot of other awards too. She has been an active member of the OPAI and was the joint organizing secretary for the annual OPAI Conference 2018. Welcome, Dr. Savri. she'll be talking on
External DCR
challenging
and
cases in external DCR.
Thank you, Neha, for
Yes.
that very elaborate introduction. That's very kind. When we send you a slide, it's just supposed to be the first two lines that you read, not something. But thank you so much. I really appreciate going through all that. Thank you, Dr. Jignesh, for persisting with me and getting me on board, which I really wanted to be. And I'm glad I've got an opportunity to present. We're definitely missing Dr. Honavar, but I'm still very glad. And I'm very glad I got to hear Dr. Ruchi because we missed her, especially at AIOC because
yes.
she bunked it. So, so I'm glad I got to do this session with her. So I'm shifting gears and keeping it very basic and simple, which would appeal to the general ophthalmologist with some videos thrown in. Can you see my external DCR slide?
Yeah.
Okay.
Sorry. Yes.
So we're going to start with the simplest of things is making a skin incision. Now, since we are talking about external DCR and there will be a skin incision, we all try to aim for, it doesn't mean that you have to be an aesthetic surgeon to get a scar which looks like this, where it is barely seen as is seen in the picture below. You basically just need to know the anatomy of where you'd like to place it. So these are some of the kind of scars that I get when I do an external DCR. There is a faint line which is seen, but it's mostly concealed. However, it's not that every patient turns out like that. Now, this is a photo of me because I've got slightly prominent eyes. So this is the orbital septal hollow. But where is that you want to place it? So one is at the side of the nose, that's one. And you have that classical teaching in post-graduation, which is before the angular vein, after the angular vein. But I think the best place is to kind of find where there's a little a trough, which is where the medial canthus is, or where the anterior lacrimal crest falls, where you can actually feel a depression to the side of the nose, or in patients who have these very deep hollows, that's also another place to do it as it conceals well. A nice way to do it is to do a very clean orbicularis dissection to identify the angular vein before, and if required, cauterize it or take it under your cat's paw so as not to have to cauterize over it, so as not to cause any subcutaneous orbicularis scarring, which I also feel can lead to a hypertrophic scar. As we go along from orbicularis and we go to the periosteum and the bone, this is something that I feel that a lot of people encounter, and we actually see a lot of it, something called as sutura nota. So as you can see, this opening which is in the last photo is actually an opening of a branch of the vessel, is the infraorbital artery. And it bleeds quite a bit. And that groove actually gives a false conception that it's an anterior lacrimal crest, when it's actually a deep groove called a sutura nota, and it always harbors bone perforators. You usually encounter it if you've taken a incision slightly away over the anterior lacrimal crest, but you can use any simple bipolar cautery or even bone wax, and it stops. So these are some of the things we have in the in our OT. Bone wax is something that I feel is so versatile, not expensive, and just a little thing goes a long way. So coming to the ostium. So this is what I was taught in my fellowship by Dr. Honavar, and somehow it has stayed with me. And this is what really works and gives me a high success rate for my external DCR. So anteriorly, we keep punching till the bone punch, claws of the bone punch or the mouth of the bone punch goes between the bone and the mucosa. But the superior limit is something, as you can see where this line is drawn, not to go 2 millimeters above the medial canthal tendon. Now, why is that? That is because if you go higher, you may encounter a variation or the cribriform plate. Posteriorly, I try to go as possible beyond the posterior lacrimal crest. So what can happen if you go too high? You can get a Rhino, you can basically get a CSF leak. So this is a diagrammatic representation. I'm sorry, my arrow doesn't seem to be working, but you get a diagrammatic representation, and where the arrow is pointing on the radiological CT coronal cuts, that's your basically cribriform plate. That exactly is where you can end up punching really high. So how do you identify it? Along with a little ooze of blood, you will see this continuous clear fluid, often with a very subtle pulsations, which means that you've gone high up. Usually, If you just tamponade it and it's a very micro puff, it will stop. And that's enough. Or you may need to retrieve some fat from an inferior orbit and place it there. Coming to lacrimal flap. Now, lacrimal flaps can either made classical in anterior or posterior. However, I tend to take very large anterior flap and trim the posterior flap as is seen in this picture below. When I'm deciding the flap, I have a small algorithm which we teach our residents, which is to decide based on syringing, actually seeing the lacrimal sac, how big, small, or dilated it is, and deciding and looking at the nasal mucosa to decide which flap should be of which size. But before that, we need to see that we don't do one thing, is that we don't end up having a thumb syndrome where we allow a part of the posterior sac to remain, which can cause a sagging. So this is how we identify it. So once you've passed the probe, you take the probe and go very posteriorly into the lacrimal sac and using an 11 number knife to make an incision all the way down to the junction of the lacrimal sac and the nasolacrimal duct. So you can see the probe very clearly is quite posterior, and I'm making an incision anterior to it as I use only large anterior flaps. Then you retract the probe, and just to be sure you've gotten come in, you're bringing out right in the middle of the sac flap. So you know that you're in the correct position. Following this, you make the sac flap. So this was a medium-sized sac. So I got good anterior sac flaps. And as you can see, I'm holding the posterior, slightly smaller sac flap, and I'm excising it flush to the lacrimal sac. Once we have done that, we assess, that's just a patty. And once we've done that, we assess the anterior lacrimal sac flap size. Now you can see I'm pulling it all the way to my nasal mucosa, and I'm getting a decent stretch without it not being too tight. I had a good thick nasal mucosa, and based on that, I made a nasal mucosal flap, which was not very large because I don't want it to sag. So you can tighten your flap accordingly. So this is something that I just teach the residents. If it's a large single flap, you may require to trim it. If it's a small or fibrous sac and you made a single flap, you need to go with a large nasal flap. And if it's a damaged mucosal flap, you need to do a large sac flap. But what if you lose either of them? Then sometimes you can directly suture a sac flap to the orbicularis or the fibers, or you can do a large nasal mucosal flap and suture it on the opposite side. Often, if there has been such amount of damage or it's a very thin down mucosa, you may do it without a flap, and this has been published by another author, and you can put in a stent. Coming to lacrimal fistulas, as you can see, that dot is not a drop of fluorescein, but it's actually a fistula, as can be seen in this video. So acquired lacrimal fistulas are away, but in the junction of the lacrimal radiate system. So often you have to try and involve the incision into the fistula and see that you do a decent dissection around it and do a fistulectomy. In this case also, she had a telecanthus traumatic along with a fistula. So we did a telecanthus correction in medial canthoplasty and remove the fistula. Now in trauma cases such as this, you often get thick calluses as seen, and even Dr. Ruchi touched upon this. You really need to take a CT and punch it. As you can see, this patient lost his eye. You may also have damaged lacrimal sacs, which you should make a note of. And often you may need to use wound modulators or even silicone intubation. Centurion syndrome is something that Dr. Ruchi talked about, so I'm not going to go into detail. But when you actually first time see a Centurion syndrome, there's some sort of awe to it, because you actually realize that there's no obstruction, there's no function. And then the patient, when you actually stain it, as you can see in the last picture, you see the subtle punctum having a standoff, which is so classical of what is described in Centurion syndrome and as it gets its name. Coming to autoimmune diseases, sometimes we do prefer autoimmune diseases to maybe do an endoscopic. We usually have an endoscope. I have the advantage of having an endoscope with me for any surgery if I need it, even in an emergency, because that's how we've worked our lacrimal system. But in autoimmune diseases where you know that the patient is already having and is on treatment, you need to escalate the steroids, you need to consider intubation, and you also need to involve the patient's immunologist, because you are going to keep the intubation for 9 to 12 months. So this is some of the wound modulators that I use, mitomycin C and the silicone intubation. And this is just a small video. So initially I used to use a 11 centimeter probe and bring it out through the nose. But now I usually prefer to bring it out directly through my external DCR. And I've switched from a 11 centimeter to what you have is a 5.5 centimeter, which is a little thinner gauge than this one. And you pull it out. The reason I only do this is because I like to see and tie the knots. I take about 7 to 8, and I've shifted from taking larger knots to a single square knot, which I'd also learned in another oculoplasty meeting. And I like to bury it well away from the opening and the flap junction, so as not for it to cause an obstruction. Finally, postoperative care is usually topical antibiotics, nasal decongestant, and maybe nasal steroids. The reason I put topical steroids is if on table or in cases such as autoimmune disease, you do feel you need to give, you could consider giving them for a period of anywhere between 2 to 6 weeks. So to summarize, be prepared for the variation. I do make a large ostium, as has been published in the literature. Ostiums as large as 20 millimeters on CT scan evaluation often shrink to 4 to 5. Design the flaps as per the nasal and lacrimal size. And even for something as a DCR, just like a cataract surgery, plan well ahead. Thank you.
Very nicely put up, Savri. In a short time, you also came out with the real pearls. My question is regarding the external DCR vis-a-vis the endoscopic DCR. Why you should prefer which, and what's the reason? Like when you should do external DCR and when you should do an endoscopic DCR? The indication, I mean. No option.
Now the thing parameters have merged a bit. So I'm going to say that endoscopic DCR, I would definitely consider, like Dr. Ruchi said, in acute dacryocystitis, because you can often get both of the drainage and the PCR done. So that's something that even I would consider. Second is even in cases such as recurrent surgeries, often people feel that external DCRs are better, which is something that I would propagate initially. But I think if you've done a good endoscopic evaluation and you see that there's not too much adhesions, and you know that the person who's gone in and not done too much, that's another thing that a re-DCR can be done. And maybe even for cases that have certain things such as autoimmune diseases, often people say it's better to do an external DCR, but that not necessarily holds true. The main thing is to evaluate it, examine the nasal cavity before, even for autoimmune cases, and often combine it with intubation. Having said that, I would say, Dr. Tasala, that I do give the option of both to the patient, with the pros and cons of both, without being biased towards another. And then I'll allow the patient to make an informed decision.
Perfect.
Dr. Ruchi, Ruchi or Neha, I think.
Yeah, just to add to it, if you have, some nasal septal deformities and all those, sometimes post-traumatic, you have a lot of, severe DNS, post-traumatic narrowing of the cavity. In those cases, either I first send them to the ENT colleagues to do things for me, put them in order, or otherwise, then I would rather go for an external approach. And of course, if you have, you suspect a tumor or something in the sac, then again, I would prefer an external approach so that I can take out the sac in totality. Yeah, besides what Dr. Sabri has already added.
What about huge size nasal polyps that is sitting inside?
Yeah,
do you go in for an external DCR or a regular?
If it is, something which is manageable at my end, it's fine. That otherwise, since I work in a multi-speciality hospital, so I always have a choice to take the help of my ENT friends. So I would rather send them to, yeah.
So you prefer
Sir, every time I ask the
DCR,
ENT,
exactly.
sir, every time we ask the ENT, oh, there's polyps or this. कोई बात नहीं, endoscopic DCR तो कर सकते. So I have learned to give the patients the options and then just say that you can get an ENT, or I send them to an oculoplasty surgeon. I work with another person because I prefer to do an external DCR, but that does not mean that I give the patient the thing that, oh, you have to do an external DCR. I give the option, and like Dr. Ruchi said, the ENT surgeon will often take care of a lot of this. And now I think a lot of oculoplasty surgeons are taking care of a lot of it also. I will have to add that.
Savri, why I asked you here in Pune at least, there are a lot of ENT surgeons who do the endo DCR. It hasn't come to us. That's why, is it prudent for all the ophthalmologists to learn an endo DCR or send it to an oculoplastic surgeon? That is another question. How difficult is endo DCR? By the general ophthalmologist, keeping a general ophthalmologist in mind.
I think Dr. Ruchi will be best to answer because she has vast numbers and she's done all variations.
So, well, I think there is nothing difficult in life to learn if you want to learn. One thing is you have to start from there. And I guess to begin with, you need to go and watch your ENT people. They give you a small bit of tips. And once you are done with it, what I did was, because like Savri, I have not had the fortune. I directly went into as a faculty. I never could do a fellowship. So I had to learn it on my own. Everything I've learned in oculoplasty is on my own. So I would go sit back and watch the YouTube videos, and I kind of, understood what anatomy it is. And the trick is that initially what you can just pass a probe, and since I was doing the laser DCR, I had that light was there, the aiming beam was there, I could visualize it. So I got the hang of understanding the anatomy and those things with that. And as far as general practitioner is concerned, let's say, I don't know how many DCRs you actually get in your practice, because not every patient you can do an endoscopic DCR. You cannot say that 100% all patients are fit for it. So whether it is worth investing so much in a technique which you will not be basically following, I think you can take help. You can have a group practice and refer it to your oculoplastic friends. I guess that's not a bad idea.
What about
endoscopic DCR requires a good amount of investment in terms of machinery and also in terms of time, learning. I don't know whether general ophthalmologists really would want to invest that much, when their primary practice is more of cataract or, probably refractive, which is, more, the number of patients are more coming to their clinic. So that also would be one of the concerns, I feel, when it comes to general
I totally agree. Only thing is, nowadays patients have started demanding, astralis surgery. The trends have started changing. So
I think it would be, it would be probably right to say that if you are about to start your practice and you don't have that technique, it's not a bad idea to take out a few months and learn it. And every surgery, just like Phaco and Femto, has a learning curve and you can master it. And I know that an external DCR works extremely well in my hands because of the variations and everything that I've done with it. So I can assure the patient that, but I also give a surety that this is, and we basically quote percentages and papers, and I say endoscopic also has a good success rate. But if there is a complicated one and they're still keen on endoscopic, and I'm not very sure that, this is something that I feel my colleague would do it, I'm very happy to refer to someone who I know would do a far better job and have a better success rate in terms of that. But I think going forward, it's something that probably people will have to eventually maybe invest and learn. I know I would like to definitely master it more than what I do.
Mainly for cosmesis. People don't want scars, what ma'am just said.
And faster rehab also, faster rehab, because patients, faster rehabilitation with, all the endoscopic procedure, may it be a revision surgery, may it be, in fact, when we compared the external with conjunctival DCR also, the patients were happy because there were no sutures, so they went back to work very fast. So
Yeah.
daycare surgeries and these things are also an issue with the working people. They don't want lot of work hours to be lost. So yeah.
Perfect.
Any
Yes,
more
Neha, any
questions?
more questions? Yeah,
No, sir. Any more questions from you, sir?
I think we had a very nice discussion. Both of them
Yes.
at the last moment they chipped in, and in fact, it was one of the best webinars I have attended on Epiphora. Though we go in the conferences,
Great.
but it was an open talk, very nice interaction, and good question and answers by you, Sauri, ma'am, and ma'am also explained it so nicely. So a big
Yes.
thank you to each one of you. Yes, ma'am, Dr. Sauri and Dr. Neha for moderating the session. And the enrolled people, they have been there always for a technical support. They would like to show the video. Yeah, Syed, are you ready?
Yes, sir.
Can we have a gallery view shot quickly? Everybody put your videos on. This is for our record actually, what all webinars we're taking, for the faculties and all. So it's nice. Syed,
Yes, done, sir.
done? Okay. Now we have our honorary secretary to give official vote of thanks. Rajesh, over to you.
Yeah, thank you so much. It was really a wonderful CME on Epiphora. Dr. Ruchi madam highlighted very well all the points on the dichocystitis, and Saveri madam showed a vivid picture of DCR. I hope all postgraduate fellows, residents, they would benefit from this webinar. Thank you, Dr. Neha, for conducting it so well. And I thank Dr. Jignesh sir also for a wonderful initiative. In spite of having AIOS 3 days before only, really I appreciate his enthusiasm to organize this webinar. Everyone. In fact, he's not well also, but still you can see his enthusiasm, and it's infectious one. Thank you.
Thanks, enrolled people also, and the August audience who have joined with us. A big thank you once again to all of you. Hope to see all of you again. Thanks, everybody.
Thank you.
Thank you.
Thank you
Can
so
you
much.
put the recording off?
Thank you very much. Thank
Can you
you.
put the recording off, please, Syed?